the topic of discussion that we are going to deal is we are going to talk about GI lymphomas, right? In this GI lymphomas, we'll be discussing about all these things. So now let's begin our discussion, right? Now talking about GI lymphoma, okay. Now initially I went through one-liner statement, and that is the most common extranodal site of non-Hodgkin's lymphoma, right? The most common extranodal site of non-Hodgkin's lymphoma, it is our GIT, right? And especially talking about GIT, it is our stomach. Now okay, now the same question, right? The most common extranodal site of non-Hodgkin's lymphoma, but in the case of patient with AIDS, right? In this case we have to take the answer of CNS, right? If there will be any patient that will present to you with AIDS, then at that time there will the most common site of non-Hodgkin's lymphoma will be our CNS, not stomach, right? Okay, now the other more non one-liner, one statement type questions. Okay, now here the most common, right, overall the most common overall subtype of our GI lymphoma is what? It is our diffuse large B cell lymphoma, right? The most common overall, right? The most common lymphoma in our GI system is our diffuse large B cell lymphoma. Now talking about other things such as maltoma, right? What is the common location of maltoma? The common location of maltoma is our stomach. Similarly, follicular lymphoma, the common location is duodenum, right? Similarly, enteropathy associated T cell lymphoma is our jejunum, and finally mantle cell lymphoma in the case of our GI lymphoma is our ileum. So okay, now okay, as I mentioned about different type of lymphomas, right, and their different position. So the first one we will memorize. First one we'll by heart our this first one, right? We'll just memorize it in any case. That means the most common type of lymphoma in our GIT system is diffuse large B cell lymphoma. And talking about these things, right, now here what is the thing is this maltoma, follicular lymphoma, enteropathy associated T cell lymphoma, and mantle cell lymphoma, right? MFEM, we'll just memorize these words MFEM, and we'll just go toward the lower region of our GIT, such as after stomach what will come? Duodenum will come, and after duodenum what will come? Jejunum, and then ileum. So it is easy, right? Now what we need to memorize is we need to memorize MFEM. What? MFEM, right? MFEM. Okay, what is M? M is maltoma, follicular lymphoma, then we have enteropathy associated T cell lymphoma, and we have mantle cell lymphoma, and just will go along our GI system. Okay, that's all. Now okay, now there is one important concept right here, important thing that we need to discuss. That is in the case of bone marrow transplantation, and in the case of organ transplantation, what will happen is we will give cyclosporine, right? We'll give cyclosporine, and this cyclosporine, what it will cause is it will cause the reduction in activity of T cell, or you can say it will cause T cell suppression, right? As it will cause T cell suppression, what will happen? The B cell will be increased in large quantity, right? Now at this time this B cell will also be increased because of Eastern vein virus, right? EPV, right? And this will happen in our stomach or in our bowel, right? So there is one good acronym, that is B cell. Increasing B cell will be proliferate. There will be proliferation of B cell because of because of EPV in the case of in the region of bowel. So this is one important concept. Now moving forward, right, now we'll be talking in detail about maltoma. Okay, as we have already said, the maltoma, the region of the location of maltoma is our stomach, right? Stomach. And this maltoma is also called indolent marginal zone B cell lymphoma. It is called indolent marginal B cell lymphoma. It is it is proliferating in slower rate, right? Now one of the main risk factor for causing maltoma is our H. pylori, right? The main factor for causing our maltoma is H. pylori. Okay. Now okay, there is one question. Okay, do gastric mucosa contain the presence of lymphoid cell? I mean, here we are asking that our gastric mucosa contains lymphoid cell or not. It does not contain lymphoid cells. So when we have infection by H. pylori, right? H. pylori, when we have infection by H. pylori, this H. pylori is responsible for causing induction of lymphocytic infiltration in gastric mucosa. right? We said that the gastric mucosa does not contain what? It does not contain the presence of lymphoid cells, right? Now what will happen in the case of H pylori infection? Our this gastric mucosa will be infiltrated by what? Will be infiltrated by lymphoid cells, right? It will be infiltrated by lymphoid cells, right? And that is what we are going to study right now. Okay, now, okay, as you can see this chart, okay, don't mug up, just go along with me. Now here is what? Here is our H pylori, right? Now H pylori is there, right? There will be what? Inflammation because of H pylori, right? Now what this H pylori will do is this this inflammation induced by H pylori, it will cause the increase in activity of BCL and MALT gene, right? It will cause the induction in, it will cause the increase in activity of what? BCL and MALT1 gene, right? Now what this BCL and MALT1 will do is they will walk through what? Downstream pathway. They will walk through downstream pathway and they will cause the increase in activity of what? Nuclear factor kappa beta, right? It will cause the increase in activity of nuclear factor kappa beta. Okay, now this nuclear factor kappa beta, it will cause proliferation of B cell, and this proliferation of B cell will cause what? It will result into low grade of maltoma, and this low grade of maltoma on getting P16 and P53 mutation, it will convert into high grade maltoma. Okay, so what we said till now is we talked about H pylori. H pylori will cause the increase in activity of BCL and MALT1, and these BCL and MALT1, they will cause increase in activity of nuclear factor kappa beta, right? And this nuclear factor kappa beta, what will do? It will cause B cell proliferation, and that will cause low grade maltoma. This low grade maltoma will be converted into high grade maltoma. That's all. Okay, now since we are talking about H pylori, right, that is causing the increasing activity of these things. Okay, these BCL and MALT, these are not just dependent on H pylori to increase its activity. So they can be what? They can be increased. These activities, the activity of BCL and MALT can be also increased because of translocation of these chromosomes, right? Translocation of 11, 18, right? Translocation of 114, translocation of 14, 18. Okay, now what this translocation of 11, 18 will do is it will what? It will sorry, I mean to I had to mention that this BCL and MALT are activated by these two translocation. And another thing, that translocation between 11 18, what it will do is it will cause what? Direct what? Increase in activity of nuclear factor kappa beta, and then the process will just go on. So one important thing that we would like to relate right here is, okay, if in question there is not mentioning of H pylori, right? If there is no mentioning of H pylori and it is talking about translocation of 11 18 to cause what? To cause high grade of maltoma, then at that time there will not be any use of providing antibiotic to the patient, right? There will not be any what? Any benefit of providing antibiotic. Look, okay, now here what I said is antibiotic will work in case of H pylori induced maltoma, right? Just in H pylori induced maltoma. Only in low grade. Okay, this is also only specific for low grade, right? If it will go through mutation, if it will convert into high grade, and at this time of high grade there will not be what? There will be not our what? There will not be our this work of antibiotics. So and at the only in the low grade, but in high grade it won't work. Okay, now okay, talking about what? Talking about as we have already mentioned, right? In mucosa, what will happen? In mucosa there will be lymphocyte aggregation, right? Okay, we'll go that thing through here. Now talking about the clinical manifestation, clinical feature, it will be presented with epigastric pain and dysphagia, right? And talking about diagnosis, what we'll do is we'll look toward microscopic examination, and we'll just, and in that microscopic examination, what we'll see is we will see infiltration caused by abnormal lymphocytes, right? Infiltration caused by abnormal lymphocytes, and this will occur in what? Lamina propria, right? Lamina propria. And these abnormal lymphocyte, infiltration by abnormal lymphocyte will also be seen in epithelial cells, and that is what we call what? Lymphoepithelial lesion, right? That what we'll call lymphoepithelial lesion. As you can see, what are these? These are lymphocytes right here. These lymphocytes are infiltrating, and these lymphocytes are also infiltrating our epithelial cells, as you can see right here, and that is what we call lymphoepithelial lesion, right? Okay, this was about microscopic finding. Talking about immunohistochemistry, what we'll see is we'll see positivity. There will be what? positivity for CD20, right, and negativity for CD5, CD23, right. Similarly 25% of patient will have what, CD43 positivity. Okay, now again let's recall whatever we studied. Now the maltoma, it is usually what, H pylori associated, right. The most common site of maltoma is what, it is what, maltoma. Yes, maltoma is stomach, but the most common site of malt is our Pierce patches or ileum. Don't get confused with these things. It is associated with what, translocation between 11-18 or translocation between 14-18, right. Usually it is what, diffuse large B cell what, lymphoma, right. Now what will be found in microscopic finding? The microscopic finding is our lymphoepithelial lesion or lymphocyte entering into a gland, right, into a gland that are epithelial origin. So this was about what, this was about GI lymphomas. So this much for GI lymphomas. Thank you.